Welcome back to the deep dive. In the world of abdominal surgery, there are organs you can mess with, there are organs that are forgiving, and then there are organs you just have to respect.
Mm.
And today, we are looking at the one that Baily and Love essentially describes as the sleeping lion of the abdomen,
The pancreas.
the pancreas. It's deep, it's hidden, it's deceptively quiet, and honestly, reading chapter 72 of the 28th edition of Baily and Love's Short Practice of Surgery, you get this real sense that even experienced surgeons are a little bit afraid of it.
Oh, they should be. It is unforgiving. There's an old saying in surgery about the pancreas: eat when you can, sleep when you can, and don't mess with the pancreas.
I like that.
Because when it gets angry, when it wakes up, it just creates absolute chaos.
Chaos is definitely the right word. And that's exactly why we're doing this.
Mm.
We've got Baily and Love's chapter 72 open in front of us. And our mission today isn't just to, recite anatomy lists or drug doses.
Yeah.
We want to interpret this dense material. We want to build a mental model of this organ so that when you, the listener, see a double duct sign on a scan or hear about autodigestion, you know exactly what story is being told.
Exactly. Think of this as your ready reckoner. It's a revision aid. We are absolutely not replacing the textbook.
No, you have to read it.
You have to go read chapter 72. You need to see those diagrams of the chain of lakes in chronic pancreatitis, the surgical planes. But what we're going to do is extract the core concepts, the mechanisms, the clinical pearls to make that reading much, much easier and stickier.
We're building the framework. So here's the roadmap for the next 40 minutes or so. We're going to start with anatomy, where this thing actually lives and why its location makes surgery so, terrifying.
Right.
Then we'll look at how it grows, the embryology, because that explains all the weird congenital stuff like the double bubble.
Yeah, that's key.
Then we'll hit trauma, and finally, the big one, acute pancreatitis.
It's a logical flow. You really can't understand the surgery without the anatomy, and you can't manage the disease if you don't get the physiology.
So let's unpack that anatomy first. Baily and Love describes the pancreas as a shy organ. Why shy?
Because it's a recluse. It doesn't like to be seen. It hides deep in the retroperitoneum.
Okay, what does that mean, retroperitoneum?
It means it's not floating freely in the abdominal cavity like, say, the small intestine where you can move it around. It is plastered against the back wall of the abdomen.
It's firmly stuck down.
Very much so. It's divided into a head, neck, body, and tail. And because it's sitting so deep, it has some very important, very high-stakes neighbors.
The VIPs of the abdomen.
Right. The head of the pancreas is just cuddled right into that C-shaped curve of the duodenum, and it's sitting directly on top of the second lumbar vertebra and the inferior vena cava.
The IVC, the biggest vein in the body.
The biggest vein. But the real nightmare for the surgeon is a specific part of the head called the uncinate process.
The text really flags this as a danger zone. Let's visualize this.
Uncinate means hooked, right?
Yes, like a hook. It's this little tongue of pancreatic tissue that extends from the lower part of the head. Now, if you can picture this, the superior mesenteric vein, the massive vessel that drains blood from your entire gut, runs right over the top of this hook.
So the uncinate process is actually tucking behind the vein.
Exactly. It passes posterior to the superior mesenteric vessels. So imagine you're doing a big resection, like a Whipple's procedure for cancer, and you're trying to remove the head of the pancreas. You have to dissect this uncinate process out.
And you're working almost blindly behind a major blood vessel.
You are dissecting right behind the superior mesenteric vein. It is a very high-stakes moment. I mean, one slip, one wrong move with the scalpel or the diathermy, and you have massive hemorrhage.
Wow.
That's why Baily and Love highlights this specific anatomical quirk. It's not trivia. It's a critical surgical danger zone.
And that shy nature, the fact that it's retroperitoneal, stuck to the back wall, that has a clinical downside for diagnosis too, doesn't it? A huge one. Because it's so deep, you can't feel it. You can't feel a mass easily. You can palpate a liver edge. You can sometimes feel a spleen, but you cannot feel the pancreas.
So a tumor can grow for a long time without anyone noticing.
Right. By the time a pancreatic tumor is big enough to be felt as a lump or to cause back pain from invading the spine, it's often already wrapped around those major vessels we just talked about. It just stays silent until it's too late.
That is sobering. Now let's talk plumbing, the ductal system. Because the pancreas is, at its heart, a factory that needs to ship its product out.
The traffic system. So you have the main pancreatic duct, the duct of Wirsung, which runs the entire length of the gland from tail to head. It then joins the common bile duct to empty into the duodenum at the ampulla of Otter.
But there's a backup road, right? An accessory duct?
Usually, yes. The accessory duct or the duct of Santorini, it drains the upper part of the head. What's fascinating, though, is the variation. Baily and Love notes that in about 10% of people, the main drainage actually happens through the smaller accessory duct.
And controlling all this flow is the sphincter of Oddi.
The gatekeeper. It's a complex little muscle that surrounds the exit into the intestine. Its job is to control the flow of both bile and pancreatic juice, and, just as importantly, to prevent duodenal content from refluxing back up into the pancreas.
Okay, so that's the structure. Let's talk about the factory inside. What is this organ actually doing?
It's doing two big jobs at the same time. 80 to 90% of the organ is the exocrine pancreas. This is the heavy lifting-making, powerful digestive enzymes.
These are the acinar cells.
Correct. They make things like trypsin, lipase, amylase, and these are powerful chemicals. They're designed to dissolve steak, break down fat, digest carbohydrates.
And this is where it gets risky. If you have a factory making chemicals that can dissolve meat, and the factory itself is made of meat.
You see the problem immediately. If these enzymes were active inside the pancreas, the organ would simply digest itself. It would be suicide.
So how does nature prevent that from happening?
It stores them as zymogens.
Zymogens, let's define that.
They're inactive precursors. I like the analogy of a grenade with the pen still in. They're stored in these little granules inside the cells, and they're biologically inert. They only get activated or have the pin pulled once they travel all the way down the duct and hit the duodenum.
So the safety mechanism is location-based. They only wake up when they've left the building.
Exactly. And if that safety mechanism fails, well, that is the entire mechanism of pancreatitis, which we will definitely get to.
And just briefly, the other job is endocrine.
The islets of Langerhans. These are scattered throughout the gland like little islands, but they only make up a tiny fraction of the mass. The B cells make insulin, about 75%, A cells make glucagon, and D cells make somatostatin. So it's balancing your blood sugar while the rest of the organ is busy digesting your lunch.
Okay, let's just pause there for a second. I really want to make sure this concept lands because it sets up all the pathology later on.
Good idea. A check-in moment.
So check-in question 1 for you. Based on what we just said, why are those powerful proteolytic enzymes stored as inactive zymogens? And what is the potential disaster if that mechanism fails?
Pause and think. The answer is to prevent autodigestion. If they activate prematurely inside the gland, they start breaking down the pancreas itself. That is, by definition, acute pancreatitis. If you miss that, rewind, because autodigestion is really the theme of this whole deep dive.
Moving on to section 2, the twisted roots, embryology. Now, I know embryology can be dry, but in the pancreas, it's actually a pretty dynamic story.
It's a dance. I like to call it the tango of the buds.
I love that image. Set the scene for us.
So early in development, around week 4 or 5, you actually have two pancreases, or rather two separate buds of tissue. You have a big dorsal bud sitting in the back, and a smaller ventral bud, which is connected to the bile duct near the liver.
And for them to become one organ, that little ventral bud has to travel.
It has to migrate. As the whole gut rotates during development, the ventral bud has to swing around the duodenum. It rotates posteriorly to go and fuse with its partner, the dorsal bud.
But sometimes the dancer trips.
Exactly. If that rotation isn't complete or it goes wrong, you get these congenital anomalies. One of the most visually striking ones is the annular pancreas.
Annular meaning ring-shaped.
Yes. In this case, the ventral bud fails to rotate properly. Instead of swinging around the duodenum to the back, it sort of stretches across it. It basically hugs the duodenum way too tight.
It refuses to let go.
And as it develops, it forms a complete ring, an annulus of pancreatic tissue that literally strangles the second part of the duodenum.
And clinically, how does that present?
It presents in neonates. You have a newborn who is vomiting bile, and when you take an X-ray, you see the classic double bubble sign.
Let's explain that visual. Why 2 bubbles?
Well, one bubble is the air in the stomach, which is distended. And the second bubble is the air in the proximal part of the duodenum, right before the blockage. And then there's nothing else. No gas in the rest of the intestines. It's a complete roadmap of the obstruction.
That is a classic board exam connection. Down syndrome, double bubble, annular pancreas.
Exactly. It's very strongly linked to Down syndrome.
Now, what if the buds rotate just fine? They get to the right place, but the plumbing, the ducts, don't connect properly.
That is pancreas diffusum. And Baily and Love says this is actually the most common anomaly, appearing in up to 10% of people.
So the ventral and dorsal parts touch, but their ducts don't actually fuse.
Precisely.
Yeah.
Normally, the two ducts fuse so that almost all of the pancreas drains through the big main duct. In pancreas divisum, they stay separate, so the bulk of the pancreas, the dorsal part, has to drain all its juices through the tiny accessory papilla, the minor papilla.
So you're trying to push a river through a garden hose.
That is the perfect analogy. And because of that high pressure and poor drainage, it can cause obstructive pain or even recurrent bouts of pancreatitis. The drainage system is just inadequate for the volume of juice being produced.
We can't talk about congenital issues without mentioning cystic fibrosis.
A true tragedy of genetics. It's a mutation in the CITR gene, which messes with chloride transport across cell membranes all over the body.
And for the pancreas, that changes the consistency of the pancreatic juice.
It turns the juice into glue, it becomes incredibly thick and sticky, and it just plugs up all the tiny ducts.
And if the ducts are plugged, the enzymes back up.
Right. And over time, the exocrine tissue, the enzyme factory atrophies. Baily and Love describes it as fatty replacement. The pancreas essentially shrivels up and gets replaced by fat and fibrous tissue.
So these children can't digest their food.
Correct. They have severe malabsorption and steatorrhea. That's bulky, oily, foul-smelling stools because they aren't breaking down the fats in their diet. They usually need to take enzyme replacement capsules with every single meal just to survive.
Okay, let's try a fictional case study to lock this embryology in.
Let's do it.
Fictional case study 1. You are a pediatric surgeon called to the nursery. A newborn is vomiting bile. The X-ray shows that double bubble appearance we just mentioned, a constriction around the second part of the duodenum. Based on the embryology we just discussed, what failed to happen during week 5?
You have to think back to the tango. This is a malrotation of the ventral bud. It didn't swing all the way around. It got stuck and formed an annular pancreas, which is now strangling the duodenum.
Perfect. Let's move to section 3, the detective work. How do we investigate this shy, hidden organ?
We've got blood tests and we've got imaging, but they both have traps for the unwary.
Let's start with the enzymes. Everyone knows amylase.
Amylase is the classic. It rises really fast within hours of an attack, but Baily and Love is, I think, gently nudging us away from relying on it as the only test.
Why? Is it inaccurate?
It's like a smoke detector that goes off for burnt toast as well as house fire. It's sensitive, but it's not specific.
Because amylase isn't just in the pancreas.
Exactly. It's in your saliva from the carotid glands. It's in the fallopian tubes. It's in the gut itself. So if someone has a perforated ulcer, their amylase goes up. If they have an ectopic pregnancy, the amylase can go up. Even kidney failure keeps it high because it's not being excreted properly.
So a high amylase doesn't automatically mean the pancreas is the culprit.
Not 100%. And there's another issue, the half-life. Amylase falls fast over 4 to 8 days. So if a patient has pain on a Friday but waits until Tuesday to come to the hospital, the amylase might have already normalized. You'd miss the diagnosis.
So what's the sharper tool?
Lipase. It is more specific to the pancreas, and it stays elevated for much longer. Baily and Love notes that while amylase is still widely used because it's cheap and readily available, lipase is the superior test if you can get it.
Now, imaging. I feel like ultrasound is the go-to for pretty much everything in the abdomen.
Usually, yes. It's the first line. But remember, the pancreas is shy. It sits behind the stomach and the transverse colon.
And what's inside the stomach and colon?
Air. Gas. And ultrasound waves hate air. They just scatter. So bowel gas is the enemy of ultrasound. Very often the report will just say, pancreas obscured by bowel gas. However, ultrasound is still absolutely critical.
Why?
Not to see the pancreas, but to find the cause. You are looking for gallstones in the gallbladder.
Ah, okay. So you're checking for the arsonist even if you can't see the fire itself.
Right.
So what's the gold standard to actually see the gland?
The CT scan, specifically a contrast-enhanced CT. This lets you see everything, the necrosis, the fluid collections, the tumors. You need a specific pancreatic protocol with arterial and venous phases to really see the blood supply and the tissue viability.
And then we have the alphabet soup of duct imaging, MRCP and ERCP.
This is a crucial distinction for anyone learning this. MRCP, magnetic resonance cholangiopancreatography, is non-invasive. It's basically just an MRI that creates a map of the ducts. It has largely replaced ERCP for diagnosis.
Because ERCP is invasive.
Very. ERCP involves sticking a scope down the throat, through the stomach, into the duodenum, and then cannulating the ampulla to inject dye. It has real risks. It can actually cause pancreatitis.
Wait, the test for the pancreas can hurt the pancreas?
Yes. By injecting dye under pressure, you can irritate the gland and trigger an attack. So nowadays, ERCP is mostly therapeutic. You use it to pull stones out of the duct or put stents in, not just to look around. If you just want a picture, you do an MRCP.
The text mentions a specific sign on these images that is really bad news. The double duct sign.
Yes, this is an ominous sign. Imagine you look at the MRCP map and you see a constriction in the common bile duct and a constriction in the main pancreatic duct.
So both pipes are pinched at the exact same place.
Exactly. And since they run together through the head of the pancreas, if both of them are blocked, it usually means there is a mass in the head of the pancreas that's growing and crushing them both. It is a very, very strong indicator of pancreatic cancer.
So double duct sign equals likely malignancy. Got it. Let's move to section 4, impact. Trauma.
The pancreas is pretty well protected. You've got the spine in the back, the ribs on the side. It takes a significant amount of force to hurt it.
Baily and Love mentions a very specific mechanism, the steering wheel, or bicycle handlebar injury.
This is the classic. You imagine a kid riding a bike, they hit a bump and fall forward, and the handlebar just jams right into their upper belly. Or a driver in a car crash hitting the steering wheel.
What happens mechanically in that situation?
The force hits the epigastrium. The pancreas is relatively soft, but directly behind it is the lumbar spine, which is as hard as an anvil.
So the pancreas gets crushed against the backbone.
It's like a hammer on an anvil. This can literally snap the pancreas in half, usually right at the neck.
So you have a trauma patient.
Yeah.
They have abdominal pain. How do you decide what to do? You can't just put a cast on a pancreas.
There is one critical decision point that determines everything. Is the main duct intact?
That's the fork in the road.
Absolutely. If the main duct is intact, if it's just a bruise, a contusion, or a small tear in the tissue, you can treat it conservatively. Drainage, observation, bowel rest. It will likely heal on its own.
But if the duct is snapped?
You have to operate. If you leave a disrupted main pancreatic duct, it will just leak pancreatic juice into the abdomen forever. That juice will digest your organs, create fistulas, cause sepsis. You cannot leave a broken main duct.
So what's the surgery? Do you try to sew the duct back together?
It's very difficult to sew such a tiny duct. Usually, if the tail is snapped off, you just remove it. A distal pancreatectomy. If the head is smashed, well, that's a nightmare scenario, sometimes requiring a Whipple's, which is a massive operation. But the takeaway for the learner is assess the duct. The duct dictates the management.
Right. Now we arrive at section 5, the SCORM, acute pancreatitis.
This is the bread and butter of emergency surgery. It can range from a mild tummy ache to multiple organ failure and death. It's a huge spectrum.
First, the definition. How do we know it's pancreatitis?
We use the rule of 3, which is also known as the Atlanta criteria. You need 2 out of 3 of these criteria to make the diagnosis.
Okay, what are they?
1, typical pain. That's severe epigastric pain radiating straight through to the back. 2, enzymes, either amylase or lipase, are more than 3 times the upper limit of normal. And 3, characteristic findings on imaging, like a CT scan.
So you only need 2 of those, which means if they have the classic pain and the high enzymes, you don't technically need the CT to diagnose it right then.
Correct. You might scan them later to check for complications, but you can start treatment immediately just based on the first 2.
Let's talk about the culprits. Who starts the fire?
Baily and Love breaks down the etiology very clearly. The big 2 are gallstones and alcohol.
How big?
Gallstones account for 50 to 70% of cases. Alcohol is about 25%, so between them, that's almost everyone.
How does a simple stone cause it?
It's a blockage. A gallstone slips out of the gallbladder, goes down the bile duct, and gets stuck right at the ampulla of Vater, that shared exit point.
So it blocks the pancreatic duct at the same time.
Right. Pressure builds up in the pancreas. Bile might even reflux into the pancreatic duct. And that pressure and irritation triggers the premature enzyme activation.
And alcohol.
It's a bit more complex. Alcohol is directly toxic to the acinar cells. It also causes the pancreatic secretions to become thicker, forming these little protein plugs that block the tiny ductules from the inside.
But there's a long list of other causes, right?
Oh yeah, the mnemonic I get smashed is very popular, though Baily and Love just lists them formally. You have trauma, post-DRCP, as we mentioned, drugs.
Which drugs are the usual suspects?
Steroids, azathioprine, valproate, thiazide diuretics are some of the common ones.
And my favorite piece of trivia, the scorpion bite.
Yes, specifically the Trinidadian scorpion, Titius trinitatis. It's a classic medical trivia fact. Its venom causes this massive release of acetylcholine, which overstimulates the pancreas into an inflammatory state.
So we have the cause, but let's go deeper into the biology. We mentioned autodigestion earlier. I want the listener to really visualize this process.
We need to, Because autodigestion sounds kind of clean and sterile, but biologically it is a complete catastrophe. It is the factory blowing up from the inside.
The zymogens lose their safety pins.
They do. The trypsinogen turns into trypsin inside the cell, and trypsin is the master switch. Once it activates, it triggers a cascade, activating all the other enzymes.
So you have elastase, phospholipase,
Yeah.
all waking up at the wrong time.
And elastase dissolves the elastic fibers of blood vessels, which causes hemorrhage. Phospholipase A attacks the cell membranes themselves, turning them into soap, essentially. The pancreas literally starts to soupify itself.
Soupify. That is a terrifying image.
It is, and it doesn't stay contained. That leakage of blood and activated enzymes tracks all through the retroperitoneal planes.
And that tracking is what leads to those famous physical signs you see in the textbooks.
Gray-Turner's sign, that's the bruising you see in the flanks. And Cullen's sign, bruising around the umbilicus, the belly button.
These aren't just simple bruises from bumping into a table.
No. That is digested blood that has tracked all the way from the pancreas through the retroperitoneum to the skin. It signals severe hemorrhagic pancreatitis. If you see those signs, the patient is in very big trouble.
And clinically, the patient looks terrible.
Awful. Severe pain, constant vomiting, profound dehydration. They're often in the tripod position. They're sitting up and leaning forward.
Why that specific position?
Because the pancreas is in the back, leaning forward takes the weight of the stomach and the other bowels off of that inflamed retroperitoneum. It just relieves the pain slightly.
Okay, time for another check-in.
Let's verify this.
Check-in. Question 2. We just said gallstones and alcohol are the big two. If a patient comes in with classic pancreatitis symptoms, the pain, the high amylase, but they swear they don't drink alcohol, what is the very first thing you need to rule out and how?
Think about the percentages. 50 to 70% are gallstones. You need an ultrasound immediately. You have to check for stones in the gallbladder or a dilated common bile duct. Even tiny stones, what we call microlithiasis, can cause this. You cannot assume it's idiopathic until you've cleared the biliary tree.
Right. Don't assume it's some mystery virus until you've checked the gallbladder.
Oh.
Okay, section 6. Measuring the storm. Severity and management.
Most pancreatitis is mild. The patient feels terrible for a few days, they get better. But the severe kind kills people. It triggers a systemic inflammatory response, SIRS, that can shut down other organs completely.
So we need to categorize it. What system do we use for that?
The Atlanta classification. It divides cases into 3 groups. 1 is mild, no organ failure, no local complications.
Okay.
2 is moderately severe. This means they have transient organ failure, so lasts less than 48 hours, or they have local complications, like a fluid collection.
Then the third one.
Severe. This is the bad one. It means they have persistent organ failure that lasts more than 48 hours.
And to predict who is going to get severe, we have these scoring systems.
The Ranson score and the Glasgow score are the classics. They measure this whole laundry list of factors: age, white cell count, glucose, LDH, calcium, urea.
We don't need to memorize the entire list right now, but what is the theme of these scores? What are they really looking for?
They're looking for metabolic chaos. High glucose means the endocrine function is failing. Low calcium means the fat necrosis is binding up all the calcium in a process called saponification. High urea means the kidneys are already struggling.
So if you score 3 or more on these scales, it's a strong predictor of organ failure.
Exactly. Renal failure, respiratory failure, or ARDS, cardiac failure, that's what kills the patient. It's not the pancreas itself, it's the systemic shock wave it creates.
So how do we manage it? What's the treatment?
The basics are supportive. There is no magic pill to stop the inflammation once it starts. Number 1, fluids. Aggressive rehydration with IV fluids like Hartmann's or lactated ringers. They are leaking fluid into their third space like crazy, and you have to replace it to save their kidneys.
Okay, fluids. Number 2.
Number 2, pain control, usually opioids. And number 3, nutrition. This is probably the biggest shift in management in the last 20 years, isn't it?
It is, yeah.
When I was in medical school, the rule was rest the pancreas, make the patient NPO nothing by mouth. The logic was, well, food stimulates the pancreas, so if we starve the patient, we can stop the enzyme production.
It sounds logical on the surface. Why did that change?
Because we were ignoring the gut barrier. The intestine is a tube full of bacteria. The only thing keeping that bacteria out of your bloodstream is the mucosal lining, and that lining needs fuel to stay healthy.
And its fuel is food passing through.
Exactly. If you starve the patient, the mucosal barrier atrophies, it breaks down. And suddenly, bacteria from the colon start migrating we call it translocating through the wall and infecting that dead necrotic pancreatic tissue.
So by trying to rest the pancreas, we were actually inviting sepsis down the line.
That's the paradox. So now Baily and Love is very firm. Enteral nutrition is better. If they can eat, let them eat. If they can't, use a nasogastric tube. Just keep the gut moving. It reduces mortality.
That leads us to antibiotics, yes or no?
It's controversial, but the general rule in the text is not for mild cases and not for prophylaxis. You don't give them just in case.
Right.
Because it just breeds resistant bugs and fungal infections. You only use antibiotics if there is a specific proven infection, like cholangitis, an infection of the bile duct, or confirmed infected necrosis.
Let's talk about that aftermath, the local complications. This confuses people constantly. The difference between a fluid collection and a pseudocyst.
It is confusing, but it's all about time. If you see fluid around the pancreas within 4 weeks of the attack, it is an acute peripancreatic fluid collection. It has no defined wall. It's just a puddle.
And if it's still there after a month?
If it persists after 4 weeks, the body tries to wall it off. It forms a thick, fibrous capsule around the fluid. That is a pseudocyst.
So, less than 4 weeks, it's a collection. More than 4 weeks, it's a pseudocyst. And why is it pseudo?
Because a true cyst has an epithelial lining, like skin. A pseudocyst is lined by granulation tissue and fibrous tissue. It's basically just scar tissue holding a bag of water.
And then there's necrosis, dead tissue.
This is very dangerous. Necrosis is dead pancreas. If it is sterile, meaning no bacteria, you usually leave it alone. The body might just reabsorb it over time. But if gas bubbles appear on the CT scan within that dead tissue...
Gas means bacteria are in there.
Exactly. That is infected necrosis. That is a surgical emergency. But, and this is another big change, we don't just cut them open immediately anymore.
So no more big open necrosectomy is the first line of treatment.
It has a very high morbidity and mortality. We use the step-up approach. You start small, put a drain in through the skin percutaneously. If that doesn't work, maybe go in through the stomach wall with an endoscope. And only if those less invasive methods fail do you proceed to a surgical necrosectomy to debride the dead tissue.
Okay, let's apply this management logic to a final case.
Go for it.
Fictional case study 2. You have a patient who had a bout of severe pancreatitis 5 weeks ago. They were sent home. But now they come back complaining of getting full very quickly when they eat. Early satiety and some vomiting. You do a barium meal or a CT, and you see the stomach is being pushed forward by a large, fluid-filled structure right behind it. What is it, and why did it appear now?
The timeline is the absolute key here. 5 weeks.
Right.
It's been more than 4 weeks. This is a pseudocyst. It has grown large enough that it's now pushing on the stomach, causing that early fullness. And it took 5 weeks because that fibrous wall needs time to mature and form.
And the treatment.
Since it's symptomatic, it's causing vomiting, you need to drain it. Usually we can drain it internally by connecting the cyst to the stomach, a cystogastrostomy, so it just drains away into the gut.
Fantastic. We have traversed the retroperitoneum, survived the enzyme storm, and managed the messy complications.
Quite a journey.
Let's try to summarize. What are the key anchors for the listener to take away from Baily and Love, Chapter 72?
Okay, let's boil it down. I think there are 5 points.
The pancreas is retroperitoneal and hidden, and the uncinate process hooks behind the SMV. That's the surgical danger zone.
The ventral bud rotates. If it fails, you get annular pancreas in the double bubble. If the ducts don't fuse, you get pancreas divisum.
Right.
3, trauma. You have to check the duct. An intact duct you can manage conservatively. A disrupted duct means surgery.
It's mostly gallstones and alcohol, so always rule out stones with an ultrasound. The mechanism is autodigestion.
And number 5?
5, management. Fluids are key. Feed the gut enteral nutrition to prevent sepsis. And know your definitions. A pseudocyst only exists after 4 weeks.
Brilliant. Now, before we sign off, I want to leave the listener with a final thought.
A provocative one.
Well, Baily and Love mentions hereditary pancreatitis, this genetic mutation that can cause inflammation. But it also carries a massive risk of pancreatic cancer later in life.
A huge risk, yeah.
So as genetic testing becomes cheaper and more common, are we going to find ourselves monitoring these ticking time bomb pancreases in perfectly healthy 20-year-olds? I mean, how do you screen an organ that is so hidden and shy for cancer before it's too late?
That is the frontier. And right now, we don't have a perfect answer. Screening the pancreas is incredibly difficult and expensive. It raises major ethical and logistical questions for the future of surgery and gastroenterology.
Something to mull over. Listeners, go open Chapter 72, look at the chain of lakes diagram for chronic pancreatitis. We didn't even get to touch on chronic today, but that visual is just iconic.
Knowledge, like the pancreas, is best when it flows freely. Don't let your ducts get blocked.
Thanks for listening to The Deep Dive. We'll see you next time.